Thank you, Mutli. You can see my slide.
Yeah.
You can see my, yeah, okay, sure.
Sir, we can't hear you.
Yeah, now, yeah, sorry. This is a 19-year-old male with history of injury to the left eye with cricket ball. Primary repair of corneal tear was done elsewhere. And 6 months later, he underwent cataract surgery and intraocular lens implantation at our own place. And post-operative visual acuity was 636. So at that point in time, he had hardly anything. You can see the corneal scar, and there is some kind of an iris injury here. But subsequently, around 10 months later, you can see a small cyst happening. And 13 months, in about 3 months, it's kind of grew this big. So this is the size of the cyst which is here, and it's encroaching on the pupil. He was having decrease in vision. So we had to do something. So the UBM shows the cyst in the retroiridal space and encroaching onto the pupil here. So this is the surgery which we did. You can see the wound which had been repaired earlier. Opened up the limbus and entered the anterior chamber, and used visco to peel the cyst from the corneal endothelium, and used the iris spatula, and used the intraocular scissor to cut at the side of the scissor at the cyst without trying not to rupture it, and dissecting the cyst and the iris from the ciliary body. And then we entered the anterior chamber, and you can see the cyst prolapsing out. The intraocular pressure was slightly on the higher side. And the iris, the plan was to resect that iris and the cyst. So now the cyst is collapsed outside the eye. The contents of the cyst did not go into the eye. And then close it up. So as I mentioned, the patient was pseudophakic. And now we have a sector iridectomy inferiorly, which we used the slip knot technique to repair it. So railroad it and bring out the loop from inside the eye using the intraocular forceps, and pass the end of the free end of the suture through the loop a couple of times or 3 times. And grab the 2 ends, and you can see the sector iridectomy becoming a peripheral iridectomy. This cyst doesn't recurred until now, and he continues to maintain good vision. So this is cutting the end of the prolene sutures from inside the eye. So that's the end of my video. Do you want me to go to the other one, or do we have a discussion now?
You can go to the next one, then we can have a discussion.
Okay, then, sure. Next one is a different one. This was a 21-year-old with family history of Warren-Lindau disease, and some of them have had retinal detachment also, his brothers and sisters. And this kid also had retinal detachment. And to make it more challenging, he had a macular hole under an angioma. The original plan was to support the angioma and the fibrous tissue with the buckle. So I placed a sutureless buckle. We went ahead with the vitrectomy. You can see PVD is already there. And he did have a macular hole also. And this angioma we hadn't treated earlier. So the fluid was coming out to the macular hole, drained the macular hole, the retinal attachment from the macular hole. And went ahead with the peripheral vitrectomy. See, this is the angioma in the periphery. So it's in the extreme periphery, almost at the ora, with fibrous tissue. So larger angiomas, I prefer to do brachytherapy, shrink it, and support it with a buckle, because you can resect it. But then more the resection, more is the chance of eye becoming tricycle subsequently. So I don't resect all the angiomas. With a bubble of perfluorocarbon and using BBG through the perfluorocarbon to stain the ILM. And the peeling of the ILM under the perfluorocarbon. I thought I'll leave it behind. So I thought, as I mentioned, I thought I'll support it. But then when I went back to dissecting the fibrous tissue around the angioma, it was very densely attached, and the retina was contracted. So I was forced to do a retinectomy and removal of the angioma. This patient is phakic, and there's a phakic base excision. As you can see, because he is young, we are able to manage dissecting the retina and the angioma almost up to the ora. You can see that the cannula. And it's just a question of how much we depress and how much suction we use. We are able to dissect the angioma and the fibrous tissue without touching the lens. Patient remained phakic at the end of it also. So as I mentioned, I don't like to resect angiomas, but this was one of the rare situations where it was so contracted, the buccal wouldn't support it, so we resected the angioma. You can see the buccal effect and the retinectomy falling right over the buccal. We reattached the retina with air and then did laser photocoagulation. So that's at the end of the surgery with the oil. Thank you.
Thank you, sir, for both those very interesting videos. Puneet sir, are there any questions from the audience?
No, there is no question from the audience.
Sir, regarding, can I ask a question?
Sure, sir.
Sir, Mahesh sir, why not do an YAG iridectomy, iridectomy for the iris cyst as an initial management in a retention cyst? Many times you can do away with that.
I have done that before. I have posterior iris cyst I have done, but in this patient, what has happened was it was in opposition with the endothelium, and there was no pigment. So this is a post-traumatic cyst, so there was no pigment for the. I have used argon laser also for it to absorb and contract it, but here I could not use argon laser. I didn't want to rupture it and create an inflammation. And again, it was in touch with the endothelium. That was the reason I thought we'll resect it.
Shanmugam, can you be always sure that once you are dissecting the cyst, because you have to separate all the lesions, and at the base of the, at the cyst, can you always be sure that you have, done the complete dissection before you prolapse it out?
Yeah, that was the original plan, Dr. Lalit, was to do a little bit of a cyclectomy also. But then, like when I prolapsed it out and used the UBM also, earlier UBM where it was arising from, that part had prolapsed out. Because in the interest of time, I have edited out that part of the video. So made sure that area where it was arising from was also included in the resection.
Okay.
Latter case, that is the angioma case, sir. What was the post-operative response? Why do we get, if we operate such cases, in spite of resect angioma, we get these patients end up in a long term after silicone oil removal with severe recurrences and then going into thysis? How do we prevent it?
So I stopped resecting it. In this kid, it was just a single angioma in the periphery, so he should do well. But like multiple angiomas, large retinectomies, what happens? They tend to throw up a severe inflammatory response with a lot of exudation and a lot of fibrous tissue formation. And that fibrous tissue is the one which causes cyclodialysis, like the traction of the ciliary body and hypotony. So what I do is to do brachytherapy, shrink the angiomas, and do a large buccal to support it, and do a limited vitrectomy to remove the traction alone. So that seems to work rather than trying to resect it extensively. That results in a hypotony subsequently.